And welcome everyone to this week's Maternity and Midwifery Hour. Welcome. It's series 14. It's the last in the series tonight, session 13. My name's Sue Macdonald. I'm the curator for the Maternity and Midwifery Hour and the Maternity and Midwifery Festivals. And it's my pleasure to be chairing this evening. And I've got two wonderful speakers. As always, I have two wonderful speakers, Susan Hughes and Emily B. Now, what we always do to our speakers is put them on the griddle and get them to share with us a moment of their week. And if I could start maybe with Emily and put you on the spot to share your moment of the week.
So my moment of the week would be that's exactly a week ago today. We had the graduation for our 2021 cohort of midwives, and it was beautiful to see them finish their student midwifery journey and start their journey as qualified midwives. So that would 100% be my moment of the week.
Well, that's a huge moment. You can share with lots and lots of people. Wonderful. Thank you. Thank you for sharing that, Emily. How about Susan? Have you got a delicious moment of the week to share with us?
So my moment of the week actually hasn't happened yet, but it's due to happen on Friday. I'm very much looking forward to seeing my 6-year-old daughter in her carol service, her Christmas carol service, in a very beautiful church. And she's really looking forward to me attending. It's not often that I can attend school things because I'm mainly doing the commuting to work and back. My husband's at home. He works from home. So she said, "Mummy, are you coming?" And I said, "Yeah, I am." So she's really, really looking forward to that. So it is yet to happen, but I'm sure it'll be delightful.
I've got shivers down my ears thinking about it. So that really is such a lovely Christmassy thing, isn't it? And I know Emily's been rushing about with services today as well. So it's that just makes you feel that's what it's all about. Thank you so much for sharing that.
Absolutely.
No, I'm just going to remind everybody now we've had some new people this evening. So welcome to the new people. You may not have come to the Maternity and Midwifery Hour before, and so welcome. This all started right at the beginning of the COVID-19 lockdown I'm having difficulty thinking of my words, in March 2020. And before that, we didn't have a maternity midwifery hour. We had lots of events and festivals and conferences and things, but we were very, very aware that midwives, student midwives, lots of people in the maternity services who attended our events really wanted something. They wanted information, they wanted professional development. And because we couldn't do anything except clinical work, it meant that we couldn't put on very much, except we set aside an hour a week where we could talk midwifery and maternity services, what was happening with COVID, how people were coping with it. And I have to say, there was some fantastic work going on to make sure that women and families and babies got the best possible care at a very scary time. But we've continued. And though we're not talking so much about COVID now, we're talking about other things, all things maternity and all things midwifery, which is lovely. So it's a time when we can really think about our practice as a midwife, maybe attend. I know that some colleagues will attend things they're not usually interested in, or it's not their usual sphere of work, but it's something interesting for them. And just to expand our horizons. Now, I also must say that everything that Maternity and Midwifery Forum do is recorded, everything. So these are recorded. So if you have a power cut or you have to be called away to a carol service, for example, or something, I don't know, something emergency, you can catch up at a later point. And you can also share this when it comes through as a podcast and as a link at a later point with your colleagues. And do that. And we love you to share things because it's a very good way. And I'm with educators this evening as well. And as a teacher myself, I know that you learn and you remember things better if you can explain it to people, you talk, have a debate. You don't have to agree, but it's part of the learning process and part of remembering and really adding to your professional development. Really, and it's good to know about this. You can get in to any of the many sessions that we've done through Matflix, which is on your resources list. And then that's really good if you're doing a project or dissertation or a degree, any essays that you might have to do, anything you have to do for project work at work. It's a huge font of knowledge that you can access and make use of. Very good if you're going up for revalidation also, I must say that. Now, I'm going to also now say, because as we come up for Christmas, it's a time when though everyone else is having a marvellous time, but we're all having to continue to provide care for our women and babies and families. And it's hard work, and there's quite a few bits of sickness going on at the moment. There's some colds and coughs and COVID also, and flu. Make sure you get your immunisation, by the way, or vaccination. So I know the people who are there are working just that bit harder than they always do anyway. So thank you to everybody for all the work you're doing. And take care of yourselves. So make sure you get your vaccination. Make sure you're getting enough vitamins. Make sure you're getting enough rest. Maybe a little bit of chocolate on the side as well. That's a personal thing for me. Now, I'm just going to veer on to the news now. The only thing I'm going to actually talk about very briefly is a report from Edinburgh Maternity Services regarding safety of care. And this was a report looking at the triage and assessment unit. And I thought it was very sort of, this comes again and again, but what they were finding, the shortage of staff, high sickness rate, always goes together, toxic culture, a little bit of bullying around as well, and a lack of experienced staff. And it really underlined for me the things that we need to constantly keep an eye on, constantly address and be aware of. And it also underlined that staff felt very undervalued and stressed. They are doing work to address the issues and improve care, but it's something that kind of doesn't go away. You have a report after report that highlights this in all parts of the country, and we just need to be aware of our own area and where there's features or issues that could impact on the care of women and babies and families, but also on the care of our students and on our own well-being. Because if you're stressed, or if you don't feel valued, or you're having to work harder than you can, you're more likely to get sick or struggle on, or even be a victim of bullying yourself. So, I mean, just be aware of that. Now, I'm going to move away from news. There's a lot going on, and I couldn't quite choose anything else that was quite relevant for us as midwives. But I'm going to give you a little top 10, and this is the top 10 of the Maternity and Midwifery Hour for this year. And these are the ones that most of you have been watching lots and lots. And we're going to release some links on Tuesday on the Maternity and Midwifery newsletter. So you can wait for them to have a look if you've missed any. Now, number 1, preeclampsia, from labour to postnatal and beyond. That was very popular. Number 2 was the power of inclusion, language matters. That was a fabulous, I can remember that. I can remember all of these actually. Number 3 was eclampsia again, an ABC of eclampsia. Number 4 was reflexology and acupressure for pregnancy and birth. Number 5 was emotional intelligence to improve your midwifery. Number 6 was water birth, a bigger splash. Number 7 was the lithotomy challenge, and that was about delivering kinder care. And that's kinder care for us. Kinder care is so important for women and their families, and of course the babies. Number 8, improving care after pregnancy, loss, or the death of a baby. And that has been in the news, and that continues to be in the news. And we need to know the long-term effect on this on parents. Number 9 was epilepsy in pregnancy and childbearing. And number 10 was caring for pregnant women with substance dependency. So look out for next week's newsletter, because there'll be some links, and it's much quicker to get into the particular episode. They do last an hour, but you could try and pick little bits of it. But I have to say, one of the health warnings I'll give you is once you start watching, you'll be hooked, which is a good thing. Anyway, so on almost on perfect timing, we're going to start the meat of this evening, and it's really lovely that we're going to be looking at learning. We're also looking at practice and how research informs our practice. And I'm so thrilled to have two midwives who will bring us a little combination of research and innovation. And you'll see both of them are bringing the both together brilliantly into their practice. But first of all, I'm going to introduce Emily B, and I'm delighted to do so, who's an assistant professor of midwifery at the University of Bradford. She's been an intensive care nurse, midwife in the birth centre and labour ward. And parallel to being in practice, as many people do now, she completed her MSc in health and community care. And she's also now, since she's moved into education, she's leading now is it a 10, it could £1,000,000. I'm sure you're going to talk about this midwifery teaching space project driven by simulation pedagogy and the vision of providing dynamic praxis-focused maternity teaching. She's completed PG cert in healthcare simulation, she has commenced actually a PhD, focusing, guess what, on simulation and midwifery education. So I'm delighted to welcome Emily this evening. Welcome, Emily. The screen is yours.
Thank you very much. So, thank you for the lovely introduction. So today I am going to be speaking to you about simulation in midwifery education, a bit about simulation itself, and then I'll go on to talk about what we've been doing as a midwifery team at the University of Bradford. So the aims of this evening are to explore simulation as a pedagogical approach in midwifery education, to discuss the new midwifery space that we have at Bradford, and I'll be looking at it from the design, development, what our vision was, and how that vision is coming to fruition now that we're able to utilise it. To share some initial feedback and experiences that we've had since the space opened at the beginning of September this year, and to discuss the potential research opportunities that the new space will facilitate. So first, I thought, as with anything, a definition would be useful. So I have looked at 3 definitions of what simulation is, and I don't think any one completely captures it, but I think actually considering them all is important for educators, because I think defining what we are going to be doing as far as simulation goes is important. So the first one is from the dictionary. So simulation is a situation or event that seems real but is not real, used especially to help people deal with such situations or events. That's in a broader context, not specific to healthcare. And then slightly more focused, simulation-based education is the pedagogical approach of providing students with the opportunity to practice learn skills in real-life situations. And the third one there is from the NMC, so an educational method which uses a variety of modalities to support students in developing their knowledge, behaviours and skills, with the opportunity for repetition, feedback, evaluation and reflection to achieve their programme outcomes and be confirmed as capable of safe and effective practice. Now, I've chosen the bottom 2 particularly, as one defines simulation as a pedagogical approach and the other one defines it as an educational method. And I'll talk about that on the slide after this one. So when we're thinking about why simulation in healthcare, so it helps students and practitioners in healthcare to gain skills, knowledge and apply behaviours that they may need in practice. It develops integrated learning, critical thinking and decision making. And the big thing with simulation is it provides a safe space for healthcare students, healthcare practitioners to learn a skill in real time, and have that safe space to make mistakes, to learn from them, but to also immerse themselves in that real time scenario, which can be really valuable. So traditionally, simulation is an education technique for skill acquisition, but now being used more broadly to improve care and outcomes in healthcare. The body of research on simulation is only continuing to grow, and as our scope with simulation, or our scope to facilitate simulation, expands with evolving digital technologies, that is only going to continue and to expand. And then simulation-based education is a valuable tool for transitioning in practice from student to midwife. And the evidence base shows that this is the same for any healthcare profession, that simulation-based education, giving students those opportunities that other pedagogies may not facilitate in the same way. So as I spoke about a couple of slides ago, so thinking about simulation as a pedagogy versus a teaching method. So this continues to be a debate. So a pedagogy would be an approach to teaching, the underpinning philosophy of teaching, of how we approach it. So much more deeper theory, whereas a teaching method would be a method to facilitate teaching. And so a lot of the research that we have at the moment focuses on simulation in midwifery education used as a teaching tool within other pedagogical approaches, as opposed to its own standalone pedagogy. And what I'm extremely interested in is looking at simulation as an all-encompassing pedagogical approach to education, because actually I think that when we think about how we look to teach, we need to think about it from a very holistic approach, how we facilitate teaching, but also how we experience teaching and experience simulation on those deeper levels, and then how that impacts our learning, our practice, and then ultimately the experience that we give to patients as practitioners, as student midwives. And so it continues to be a debate, but I hope that with evolving research and evolving implementation of simulation as a pedagogy, we'll have some more evidence to underpin it, to underpin the philosophy ourselves. So the bottom two kind of arguments there. So Earl and Mattel argue that simulation is not a pedagogy but a teaching tool, and that it lacks the philosophical underpinning. The lack of philosophical underpinning justifies this definition, which, as I said, I'm hoping that particularly with evolving research, hopefully with my own research, that will add to that justification. And then Cook et al. Say it is a pedagogy, and it improves learners' skills and behaviours and can improve patient outcomes. But the debate is still there, and as it said at the beginning, anything is subject to healthy debate. So it's hopefully something that will continue to evolve. So different types of simulations. So we've got unfolding case studies, high fidelity mannequins, low fidelity task trainers. We've got things like remote simulation, which we can facilitate from online from different locations, role playing and use of actors, the use of VR and AR, things like tabletop simulations where we're looking at, for example, looking at award, patient allocation, anything there. We've got e-learning. And one thing that I've missed out on there, which is only going to continue to evolve, is the use of AI in simulation, which I think, again, over the next few years is going to become more and more prevalent, probably interwoven with a lot of the ones that are listed here. But I think, again, that will be very transformative in how we deliver any education, but also particularly simulation. So advantage and disadvantages of simulation. Oh, I apologise. So the advantages: it offers a diverse approach to learning. It enables diverse and flexible learning for students. It helps to bridge the theory and practice gap. So because simulation is facilitated in what it can be a very immersive environment, a real-time environment, particularly, and there's a lot of research, if it's an interprofessional environment that simulates practice, it can really help to bridge that theory practice gap. And then in the debriefing aspect of simulation, a lot of the deeper theoretical learning can come into that. The evidence base shows that it improves student knowledge compared to traditional learning methods, and it can improve student confidence. So we are giving learners the opportunity to potentially access situations that they may not be able to access in practice if they're uncommon, or giving them the opportunity to access them before they then have to manage them. And the evidence base is really good for supporting that development in student confidence. The disadvantages of simulation, as with anything, there's always disadvantages. It is very staff and resource heavy, so it takes a lot of planning, a lot of logistical input, and it needs a lot of staffing to run effectively, because if we want to make it authentic, real time, we want to be able to sort of really debrief people, make sure we're ensuring their psychological safety, then we need those high staffing levels to meaningfully facilitate that. So it can rely on a flipped classroom approach. So what I mean by that is actually giving students quite a lot of pre and post reading materials, particularly pre, to facilitate the content in the session, which then obviously relies on an engagement. One barrier can be it may not be realistic to students and can prevent that immersion. So depending on the modality of simulation, particularly talking about face-to-face simulation in real-time simulation environments, there can be, particularly with some of the high fidelity task trainers, there can be a concept that we call uncanny valley, where actually we are using human-like representations such as mannequins, but actually that they are not human, and that can create a barrier to learning with that and a barrier to that immersion in the situation. So again, with more research and development as to how we use technologies, that is integral to sort of overcoming that barrier. And also it can be very time consuming as well. As I say, it's something that needs to be facilitated potentially in smaller groups, and so it's something to consider when planning that. So onto the teaching space. So at the University of Bradford, we recognised as a team it was a time for change in how we delivered midwifery education. And this was 3 years ago in the summer of 2021. So we were getting into that post-COVID environment. We had a new curriculum, and we needed to look at how we were going to continue to change the way we deliver teaching for our future midwifery cohorts. So the previous room we had was too small for the expanding numbers. We'd had successful HEE bids for procuring more equipment, but actually didn't have the space in which to house and facilitate that equipment for teaching. COVID obviously was completely transformative in the way we live. A lot of the ways we live, and one way was that in how we approach teaching. So thinking about immersive technologies, blended learning, and how and embedding the digital into our teaching and lives. So that was again thinking about how we can utilise that, improving student experience. As we know, students did. It was a very, very challenging time for students, all students, but particularly healthcare students. So we're looking to improve that, implement improved simulation and digital technology into learning. So one of our core aims when we started this project was how are we going to keep the pedagogy at the centre of it. So in our design, our facilitation, we want to facilitate a simulation pedagogy. We also use problem-based learning, and we wanted to be able to facilitate a dynamic space that was practice-based learning. So bridging that gap between theory and practice to make learning as real as possible for students. So we spent 18 months building a business plan, and then we got a £1 million funding to then start work on our new space. So the vision was a multifunctional dynamic space driven by implementing a simulation and problem-based learning pedagogy. I know I've said quite a lot of this, so that's why I'm blasting through it. Enables blended learning. So we looked at things of how can students access remotely. We've got some blended learning programs and midwifery programs at Bradford. So how can we facilitate that and then enhance learning? How can we facilitate high fidelity simulation as well as low fidelity simulation? So we looked at some integrated simulation based software and how we can embed the hardware to facilitate that. Building for different learning styles. So, we're very much at Bradford, we want to facilitate we want to facilitate everybody to learn. We don't want to subscribe to one way of learning, because we actually we recognise, as I'm sure all institutions do, actually the value of different learning styles and the value that different people bring to that. So actually what we very much thought about at the core was how can we look at facilitating different learning styles within our teaching space, and then building that into our teaching curriculum and our sessions. And then looked at embedding digital and immersive technologies to enhance student learning knowledge and experience. So this is one of the plans that we had. So this space, this did become the space. This was our initial plan. Everything on this this plan, so all the chairs, all the tables, everything is on wheels. Everything is movable, because we wanted, like, we're doing this session, what do we want it to look like? So to make it a completely dynamic space. So none of all the, I don't know if you can see my mouse, but all these jagged lines, they were just examples of how the space could be used. They are not actual physical dividers. Here's another example of the room set up as a lecture, in a more traditional lecture. So this is what the room ended up looking like as a plan. I don't know if everyone can see my mouse, but on the left-hand aspect, so this top grey bit is a more of a hospital high-risk area, where we facilitate the simulator high-risk simulations. And this, we've done triage, and we've done enhanced maternal care, more of that hospital focus. And this bottom bit is, and we particularly wanted the floor to look different, because again, just thinking about that immersion, could be a home birth, could be a community clinic, but I know it sounds something simplistic as a floor, but actually we wanted that feeling. And then the colourful floor as well. Again, we wanted it to be waves, we wanted it to be colourful, we wanted it to be calming, sort of tried to think of everything to kind of really make it a holistic, dynamic space. And in these spaces here, we have a breakout room as well. So we use that to facilitate some smaller group teaching, but also particularly when we're thinking about simulation, it's there as a breakout room. So it can be there for if people need to take a break. So we're thinking about sort of preserving psychological safety. It can be there as a holding room is probably not the best terminology, but say if it's an evolving simulation session, if somebody pulls the emergency buzzer, it will go from that room. So again, just thinking about how when we design the space, how we could utilise those different areas, and the importance of having something separate to the main space. So the digital technologies we have in the midwifery space, so we have SimEPR, which is simulated electronic patient notes. So this has been really useful. It is a platform that is not affiliated with any EPR system used in the country. It is purely made for simulation and learning. So it's really good for teaching, and also so students get the experience of using an electronic patient record, but then we're not teaching them how to use a specific system, because the students, access diverse locations of trust. We've got things like HoloLens, which has AR capability. We have a big LED wall, the sim control room, as I mentioned. Learning spaces, the simulation software. Sorry, if I'm going quickly, I'm conscious of the time. High fidelity mannequin, and technologies to support. I put at the bottom, the technology is there to support simulation, not to replace human interaction. So what continues to drive our learning and our teaching is our delivering holistic education, delivering midwifery education and woman-focused education. And although we've got this amazing room, we've got this amazing technology, that still remains at the core of it. The core of what we do is for the women we care for, and to keep those core midwifery values. So that's why I kind of put that there, because what we've got is amazing, but that is why we're doing it, and that is what we want our focus to continue to be as a team. So here are some pictures of what we've been using the room for. So we've had some IPE, that if you can see, the floor kind of gives it away which bit of the room it is, but so we've got at the top left-hand corner that we had a home birth scenario with sort of our team. The top right-hand corner, we had a fantastic IPE session with our physician associate colleagues, and the lady on the bed there is an actor who was in early labour. We've got the big group is a debriefing session, and then we've got how the room could be set up, clinical skills So it's a really, these are just some examples of how we've been using the room in 3 months, but the scope of how we can use it as a dynamic teaching space will just continue. Initial feedback from students has been very positive. Students have valued having their own space. They've enjoyed being able to access the midwifery equipment. So even when we're teaching more of a traditional lecture, we can then, we have our kit available. So actually we can then bring in those practical elements into what would normally be a traditional lecture if it was a non-midwifery space. So again, to really bridge that theory practice gap and to teach in a more diverse way. And the initial evaluations of the simulation sessions have been well received. The room itself, it is going to be the start of us building our a research community at University of Bradford and beyond. So we've got research looking at the use of embedding simulation midwifery, research looking at digital technologies to support simulation, facilitate holistic learning. One of my colleagues also has a very specialist interest in digital technologies, so looking at that specifically as well. We're very interested in making sure what we design, as I say, is meaningful. So we're looking at co-creation with students, with service users, again, to make the simulation and practice partners, of course, but as real as possible, and to think about the impact on practice, patient safety, interprofessional opportunities. And I've put at the bottom, it facilitates a broad spectrum of research projects through accessibility and technological capabilities. So even beyond the subject of simulation, we're hoping it just starts that research community and students and staff coming with ideas and really building that, and looking forward to the future. Just over time, so I do apologise, but thank you very much for listening to me and having me on. I really appreciate it.
Emily, thank you so much. Goodness, you must be very breathless now. So take a few breaths. I know. I think what Emily really illustrates is when you have a passion for something, you want to include lots of things and lots of information. That was fantastic. Really loved the fact that the core is the midwifery values and the care of the women and babies. That's fantastic. Now, if you have questions for Emily, just pop it in the chat box and Paul will send it through to me, and that's why I keep glancing over here to see if Paul sent me any questions from the audience. So please get questions in. But next, we're going to go to our next lovely speaker, and I'm delighted to introduce Susan Hughes. She's a consultant midwife with a joint post. And this is really a huge thing of having a joint post between Gloucestershire Hospitals Trust and Worcester University. She has over 20 years clinical practice as a midwife and came through midwifery through the nursing pathway. She's held roles as community team midwife and later as delivery suite coordinator on labour ward. She's skilled in high risk and low risk maternity settings. And she's got a huge interest in home birth and physiological birth, believing home birth can enhance feelings of control, comfort, and can provide a truly personalised birthing experience for women in familiar surroundings. So I'm delighted that she's able to share her research with us. And thank you so much, Susan, for coming. The screen is now yours. Maybe there's not. I'm hoping there isn't any gremlins in the system for Susan. Going on. The sound. Susan, you need to unmute yourself. Sorry.
There we go. Can you hear me now?
I can hear you perfectly. Thank you.
Right, I will just share my screen.
Excellent. For a minute, I thought we had the gremlins in.
Can you see that now? Lovely. Okay, thank you very much, Sue. That was a lovely introduction. So following on from Emily's great talk, I'm going to talk to you this evening about midwives' perceptions and experiences of home birth. And this was a small qualitative study that I undertook as part of my MSc in advanced practice. So really delighted to be able to share these findings with you this evening. So I picked this image that's on the title page here, saying positive home birth, because I think it perfectly encapsulates and depicts the absolute sheer joy of a home birth for mums and also for midwives. And this must have been carrying on from the theme of COVID. This must have been during COVID, because that midwife's wearing a mask. And I do believe that due to COVID, the home birth rate did go up and increased as a result of that, which had some sort of positivity to it in that sense. So I know there's lots of students on tonight. I've been told that some of the students that I teach actually are here. So lovely to see you and welcome you here. And I would just encourage all students and any midwives that if you've not undertaken or been at a home birth before, then really it is such a great opportunity, and you should really grab that if that opportunity arrives for you. Because for me, it really did spark an interest for me. I wasn't fortunate enough as a student midwife to attend a home birth, but as a qualified midwife, particularly working in the community, where I worked on as a team midwife for over 4 years, which is a very similar model to what we now call continuity of care. I was able to attend many home births, and I really, really enjoyed that experience. And I think it is a fantastic way to deliver person-centred care. And just following on from what Emily was saying about, it's all about developing those sort of core midwifery values, really. So it's really at the heart of that. And I just wanted to say my background in both, so high risk and low risk, as a delivery suite coordinator and as a community midwife, has allowed me to see both sides of the coin, and has really strengthened my passion for physiological birth and home birth, mainly really because I think we see a lot of iatrogenic harm in the clinical setting. We're seeing that rise, aren't we now, of induction of labours, which can cause PPH, it contributes to those PPH rates, and obstetric anal sphincter injuries, and not to mention the huge rise in post-traumatic stress. So even more reason, I think, to be very supportive for physiological birth, particularly in the home setting, which is very different to the clinical setting. So the aim of my study then was to explore midwives' perceptions and experiences of home birth. And in the UK, currently the home birth rate sits at around 2%. Sometimes it goes a little bit above that, a little bit below, but approximately it always remains around about 2%, with a healthy home birth rate aiming to be achieved for around 4%. At the trust that I worked in at the time of undertaking this study, our local home birth service had been developed, which was great. However, there was no formal review since its implementation in terms of its effectiveness. And midwives' perceptions and experience of home birth had largely been explored, both from within the wider literature of doing a literature search, but also in that locality also. So talking about some of the background then, and looking at home birth. So as part of that literature search and studying home birth, what was found was that home births are associated with significant health benefits, not just for mother, but babies also. And obviously there's always a cost implications in there to the care that we provide. So overall, the cost effectiveness to the NHS is driven down. So the two main colleges, which I think is really wonderful, the Royal College of Midwives and the Royal College of Obstetricians and Gynecologists, support home birth for women with uncomplicated pregnancies. And I would recommend that you access the position statement on that, because both colleges are very aligned in that respect. And I think it's something that we often don't pay attention to as much as we perhaps should. I'm sure we've all heard of the home birth, the birthplace study, which is a landmark piece of research which confirmed that for low risk women, giving birth is generally very safe at home. And the observational data available demonstrates that there are lower intervention rates and much higher maternal satisfaction rates with planned home births compared to hospital births. So all really, really good and positive information out there on home births. However, despite the Royal College of Midwives and the Royal College of Obstetricians and Gynecologists support for home birth, relatively few women choose to give birth at home. And I think we see that, don't we, on a day-to-day basis in the hospital setting. We've got a really high birth rate, but actually home birth rates tend to and have been tailing off over the years. The NICE guidance recommends that women classified as low risk for complications should be supported in their choice of where to give birth, including the option to birth at home. And there is a continuing variation in UK home birth rates between local health authorities from region to region and county to county, some experiencing home births as low as 0.5% and those experiencing much more success and higher rates of 14.2%. So we know that demographics definitely plays a role in this as well. But there is also that question to ask, and one that I've always considered, is home birth a setting that's truly being offered as a place of birth with respect to supporting women's choice? So having performed a literature search, the literature demonstrates that midwives' attitudes towards home birth are largely positive, which is a great thing. There's lots of literature out there that demonstrates that women are very happy with home birth and they report positive experiences. But there's not as much literature on midwives' experiences, but the literature that is out there is positive nonetheless. There is acknowledgement that experience, essential clinical skills and competencies are required to provide safe care, and that midwives play an important role in promoting home birth, thus improving home birth rates and facilitating women's choices in achieving normal physiological birth with reduced medical complications. It does, however, seem that there is it's possible that there's a lack of clinical resources, which does little to support the facilitation of home birth. And we know that we're experiencing staffing issues nationwide, aren't we, in midwifery? And that can definitely impact on the provision of home birth and the ability to support home birth from a leadership perspective. But we can't ignore the possibility that midwives' perceptions of home birth have a direct influence on the choices women make on place of birth. The next slide is not. Here we go. Methodology. So the study was carried out in a maternity unit encompassing an obstetric-led unit, a co-located birth unit, and a standalone birth centre, and a dedicated home birth team. So one of the largest maternity units in the southwest of England, with a birth rate of over 6,000 per year. I needed to recognise myself as an insider researcher, because at that point in time, whilst I was undertaking the research, I actually worked at that particular maternity unit. And I think being an insider researcher has its negatives and its positives. And the positives are that I knew the staff, so I could build those relationships very easily. They trusted me to be able to share that information. However, we know that one of the negative things is, are we 100% confident that what people are telling us is as transparent as they want it to be, or are they more reticent because they know you and the position that you hold within the maternity service? I arrived at a predetermined purposive sample of around 10 midwives. That was what I had in mind to interview. And that sample was drawn from midwives working in midwife-led settings, just to elicit the participants' perceptions and experiences of home birth. Initially, I wanted to interview midwives that worked as core midwives on delivery suite, and then interview midwives on the home birth team or in the community. But the study was getting too large, so I had to sort of tailor it down. So perhaps that's a study for another time. So ethical approval was granted by the Trust Audit and Research Department and from the University Ethics Committee. And I would say actually that took much longer than I'd anticipated. So if you are thinking of undertaking a study, I would get your ethics sorted as soon as possible as a priority, because it can take much longer than you realise, particularly for an RCT. That can take a very long time. The data was collected by means of semi-structured interviews, and all of them were held via MS Teams. So there was some consistency, and they were all transcribed verbatim. And this again took much time. So really, there's quite a lot of challenge in terms of getting and collecting all the data. To ensure confidentiality, pseudonyms were assigned to conceal the identity of the participants, which was really important. And I used an interview guide which was informed by the aims and objectives and the literature review. All the midwives were provided with a participant information leaflet and a consent form via email, and the data was collected. It was stored on the university encrypted OneDrive in accordance with the university data protection policy, and it was destroyed after. All of the interviews were anonymised and given a number only known to myself, and once indexed and coded, they were also, as I just said, destroyed in line with research ethics guidance. To analyse the data, I used Braun and Clark's thematic analysis framework, which you can see here on the screen, and I found that particularly effective because it offers a flexible approach, and it's rigorous and very accessible, and really helps identify and analyse and report patterns. So I've really familiarised myself with the data, read and reread the scripts, and then generated some initial codes, assembled the data relevant to each code, and then searched for themes, assembling those codes into possible themes and gathering all the data pertaining to each possible theme. Reviewed the themes again, so checked the themes relate to the codes extracts and the entire data set, and then generated a thematic map of the analysis. And then following this continuous analysis to refine specifics of themes and overall themes within that story, to generate clear definitions and naming themes, and then eventually produce the report. It is important actually to say that the data saturation was reached on the 6th interview, and therefore no further interviews were required following that. So same themes were coming out from the midwives, which was really pleasing to see. So the report identified then that there were 4 themes, and this was that exposure to home birth enables not only a greater insight into physiological birth processes of birth, but also offers a profound understanding and deep respect for the female body. Exposure to home birth to increase confidence in midwives was seen as pivotal to improve the home birth rate and challenge existing barriers that home birth is not regarded as a safe option, and sometimes particularly midwives in the hospital setting that work on delivery suite may think. So it really showed to me that there was a completely sort of different mindset, if you like, and approach to home birth. Also, clinical skills and proficiency in managing emergency situations was seen as critical to the confidence levels of midwife in providing home birth. However, and I think this is quite important, those midwives recognised that these skills were necessary and specific to the home birth setting, but they were also careful not to pit these against skills recognised within the hospital setting. Midwives believed also that management and leadership is central to the effectiveness of the home birth service. And without effective leadership to support service improvement and the continuing development of home birth, there is a risk that inadequate staffing and a lack of prioritisation of the home birth service would exist within the overall structure of the maternity service. And I really believe that last point is so true, because actually if you don't have your leadership and management team behind it, it can be really difficult to achieve a really successful home birth service. So some of the implications for practice are that midwives that practice in the home birth service should be offered regular home birth specific study days to include clinical skills update, emergency skills and drills training, review and discussion of case studies, those that have gone very well and those perhaps where there is some identified learning, and also celebration of home birth targets and achievements. Also, home birth needs to be protected by ensuring there is adequate staffing to cover the service with appropriate escalation to manager on call should acuity of the unit impede delivery of the home birth service. Adequate support from management and those that hold key leadership roles should include promotion and celebration of the home birth service, and also internal rotation by less experienced midwives to the home birth team with adequate support by using a buddy system with a more experienced midwife. And I think that area really warrants further exploration, because I think that's the sort of key really to getting midwives on board with home birth, to increase these opportunities for women, because often it's because when you unpick it, midwives actually express that they don't feel confident in the home birth setting. So teaming midwives together, one that's more experienced with a lesser experienced midwife, can help sort of cascade those essential skills and build that workforce that supports home birth. And also collaborative working with the university to explore ways of including home birth as an essential component of practice for student midwives. And I recognise that is challenging, because if we've got a low home birth rate, then everyone's, fighting over to go to a home birth. There are ways around that in terms of perhaps students being identified and being able to be put on call for that home birth service, so that they can get that experience and that opportunity to be able to help and support in a home birth setting and learn. So some of the limitations then, because we always know that research has its limitations. The researcher, myself, acknowledges the service evaluation was undertaken in one setting, which could be perceived as a potential limitation of the study. It is important, however, to stipulate that in keeping with the qualitative inquiry, it was not my intention to generalise the findings. It was just within that one setting. Also, there was no peer review of my data, so it was just undertaken by myself. So obviously there could be some biases within that in terms of the way that I interpret the data. However, I was reflexive and kept a reflexive journal in order to be able to mitigate that bias. And it was believed that participating midwives sharing their unique insights into home birth and a rich and meaningful account would deepen the understanding of any unmet needs in which to inform service development within the local setting, as a positive from that. And then just to conclude, exposure and personal philosophy on home birth alongside investment in specific home birth training could increase the confidence levels of midwives to provide the home birth service. And ultimately, home birth rates could be increased with a supportive leadership and management team to truly embed home birth within the heart of the service. And I'd just like to end by saying I've been particularly naughty because I haven't appropriately referenced all the way through, although I do have my reference list here. So it's a case to my students of do as I say, not as I do. I hope you enjoyed the home birth presentation.
Thank you so much, Susan. I like the last point of your referencing, and that just leads me to remind our audience that there are a whole lot of references. You don't have to read all of them, but there are some delicious references from both Emily and from Susan that you can access. And these days it's very easy to get the information. You don't have to pour through big books to get them. Thank you so much, Susan. Thank you, Emily. Also, I can see some kind of a bit of sharing going across here, because as I was sort of, I've jotted down on my little notes here that I'm sorry I got the sum of money wrong at the start, Emily. It was £1 million. When I read it, I thought they couldn't have got £1 million for that space. But how fabulous is that? Not just to focus on learning for midwives and presumably for student midwives, but also for midwives, presumably. So my question to you, Emily, you were talking about student midwives, but are midwives able to access the space? Because as Susan was talking about the confidence of caring for women through home birth and the sort of, the difference in providing care in a home setting, and I thought about your little brown floor and your home birth setting, which I have to say all the space looked lovely and spacious, better than some of the houses that you have to care for women in, which often are like normal houses, aren't they?
We, currently, because the room only opened in September. We are kind of looking forward as to what we can facilitate. My example probably fits in completely the opposite end of home birth that I'm about to say, but it's not not within our plans to look to do it. So for qualified midwives, we ran an enhanced maternal care master's course, and part of that was a full week of simulation. This was prior to the room opening, obviously with the vision to utilise it in the room. But again, part of that. So similar to what Susan was saying, my background is I did intensive care, and I also then worked on a birth centre. So actually that value of bringing in those core midwifery skills to women who become sick, and actually seeing the human experience in the middle rather than the machines and the technology and the presenting complaints is very key. And bringing that back to looking forward, what we would like to do is facilitate short courses, days, weeks, for practitioners, hopefully from a co-creation perspective, to provide meaningful simulation for practitioners. So we are, as we are at the start of our journey with this space, we are looking to whatever we can do to facilitate meaningful learning for I suppose the midwifery community, isn't it? Not just our student midwives. So it's have we done it? No. Do we want to do it? Absolutely. And we're looking at however we can facilitate that and utilise our space to, as they have that ultimate impact on practice, patient safety, and women's experiences. That's a really nasty answer. I do apologise.
No. I think that really sums it up, really, because I mean you've set up the space and it's fairly new, and your focus is obviously going to be on student midwives. But what we all know as practitioners, you need to make sure that midwives are getting their development. And sort of thinking of what Susan was saying about people not feeling confident, it's on the other end of the intensive carey, high risk kind of way of getting midwives to think, well, okay, you're in the home, well, this could happen. And I'm thinking the scenarios that you can provide for midwives to make them realize, or help them realize, not make them realize, that actually for most women birth is normal physiological event. But Susan, did you want to say anything on this?
No, I was just thinking actually that if for simulation purposes, it would be great, wouldn't it, to use that and utilize it to reenact sort of home birth, particularly like all the things that could potentially, and you don't want to focus on what could go wrong, but actually there is a reasonable chance if, say, core prolapse, which we know from diagnosis to delivery time, if that interval is shortened, the outcome's better. And we know in the community that there's a high likelihood, if that happens, that because of that delay of getting to the hospital due to calling the ambulance and the ambulance transfer, that can be really worrying. So for something like a core prolapse, that would be amazing, wouldn't it, to be able to simulate that in practice in terms of how we facilitate a safe transfer to hospital, in terms of, getting mum walking downstairs, that where she is within that building, and what we're doing to, it's kind of more of a hands-off approach, isn't it, and to not touch the cord because you don't want it to spasm. So that it would fit really nicely with that, wouldn't it? And I think simulation can really open up things, particularly we're on that sort of cusp, aren't we, with AI. So I think it's really going to transform practice and education entirely, isn't it? Yeah, for a good thing, but mustn't forget that human aspect. And I think that's something that I think really lends itself within the home birth setting, because it's just a completely different environment, isn't it, and an atmosphere than, say, the clinical setting that tends to be. I know most birth centres are very dark, and they try to replicate that home birth setting, but there's no getting away from it. It's very different than the woman's own environment, which she's used to, which impacts the release of hormones.
Yeah, absolutely. That's fabulous. I'm just very envious of that space. And all my mind as a teacher is going, I'm almost designing a little scenario in my head for home birth. That's another story. And now I've got Juliet Samuel. Now she's one of our regulars. Hi, Juliet. I hope everything's okay. And she says, Emily, well done. Your enthusiasm is palpable. Do you have within your simulation space a facility for video recordings to aid reflection and learning?
Yes. So what we had embedded was so we had hardware embedded. So we've got built-in cameras and microphones embedded, but that is coupled with with software called Learning Space, and it's something that is that is designed purely to facilitate simulation. So it will capture the simulation. People can watch it. People can engage with it remotely. They can engage with it in another room. They can engage with it within the room. It synchronizes with, for example, we've got our birthing mannequin. But the beauty of it, whether you're using a high fidelity or low fidelity sim, is that you can watch it back, you can time mark it, and you can use it for debriefing. You could use it for learning. So learners could use it to reflect on their own practice. So we could capture a simulated scenario and debrief as a group. We could capture it, debrief individually. So potentially, if we've got some students that are present and some students that are accessing remotely, it can do that. But also, even beyond that, we could record something as a teaching team or as a group of practitioners in a simulated scenario, and then get practitioners to reflect on that. And it's people can have individual debriefs. They can write it down. So it really facilitates that the diversity of how we can learn with the simulation. And the thing is, with simulation, is the learning is within the debriefing. So actually, the depth and the breadth to which we can now do that is absolutely huge. So yes, we do, and it's quite exciting as to what we should hopefully be able to do with it.
And that was a brilliant question, actually, because it is that, as you've actually underlined, Emily, it's the reflections is when the learning is actually connecting to the physical doing of the thing. So that fantastic. And I'm thinking now, I'm going to go to Susan now, because I'm just thinking, was there anything that surprised you in your findings of what midwives were saying or what their perceptions were?
So one of the things that would come out, I sort of asked, do you think continuity of care would make a difference to home birth? And actually, I think only sort of one midwife mentioned that she thought that it might. And then a lot of the midwives didn't feel that it would. But and which actually, for me, I had to really grapple with that, because I'm a big believer in continuity of care. And so I would naturally think, because you're looking after somebody and you've got that contact and that consistency and that continuity, you would be in a position to be able to influence women in a positive way. So that was quite interesting. I was very, very keen to interview delivery suite midwives, but that couldn't happen. And I just really wanted to understand the thinking, because I think that's where the kind of gold dust is, isn't it? Because it's of no surprise really that community midwives and home birth midwives, they're there because they believe in it, aren't they? That's it. But I really wanted to get to the kind of meat, if you like, of the delivery suite midwives, having worked there myself and seeing that there is just that my lived experiences, there's a completely different mindset, and is that something that is that a cultural thing? Are you in that culture? And so therefore the reinforcement of the information that you're hearing and sharing and what you're seeing on the receiving end of, because obviously when home births are transferred in, mostly with primates, it's unsatisfactory progress, but maybe it's those situations where things haven't gone quite right, and so their feelings, if you like, are sort of skewed from the experience that they're seeing. So but yeah, so hopefully that answers the question.
Yes, it does. It does. I mean, I liked, I have to say, this is all from scribbles I've got, the buddy system. So how could that work, do you think, with your thinking back? Because it sounds as though the labour ward and would you be able to take one of those labour ward midwives out?
Yeah, and I think the key is really trying to get in there even before they qualify. So student midwives having that opportunity. I saw the other day a community midwife come back with a student midwife. They'd just been to home birth, and she was just overjoyed that she'd had that experience. So she was, she considered herself to be really lucky, but thoroughly enjoyed it. But yeah, I definitely think there is room for like a rotational post within a home birth team. With a rotating midwife, or maybe even a secondment from a core delivery suite midwife to come out to the home birth team. And I think that kind of, if you've got the system behind that and the leadership behind it, there's more potential for that to happen. Because I think it's just that I think you have to be there to experience that and believe in it, because unfortunately, I think when you spend too much time on somewhere like delivery suite, which is a high-tech area, you start to think that nothing is really normal any longer, and then I think it is quite, insidious, isn't it? So it just develops over a period of time that nothing's normal. Everybody goes for a section, everybody's induced, and so it can become very clinical and kind of very high tech, when actually it could be quite different, couldn't it? And our environments are so important in terms of the hormones that we release and that like feedback mechanism.
Which goes for the midwives themselves, because their hormones are going to be around.
Totally.
And I'm thinking, you do lose your confidence, I think,
Yeah.
once you've been in a hospital setting. And I'm thinking this would work for Emily's space. I'm thinking work for you for the future, Emily, of getting students and midwives kind of getting to experience the simulation before they get to go on Susan's buddy system, because that would be, for me, would that be perfection? Because that way you get a little go at it and simulation, which would take away some of the fear, and then the buddying system would kind of finish things off beautifully. I don't know, Emily, what do you think?
I mean,
would that work for you?
I think it sounds like perfect. It's research-driven simulation, which is what it should be, and then it would be navigating and challenging embedded cultures. For example, what Susan was saying about delivery suite, that sort of, once you become immersed in it for several years, that perception of nothing is normal, actually it becomes very intrinsic, and actually through I think through simulated education, and then building on it, for example, with the buddy system, with rotating around, actually what it does is it's challenging something that has been long entrenched in midwifery, that move towards that more medicalized model of care, and it's challenging it from the start, and actually connecting on a holistic level, actually a holistic educational level. So I think it would be ideal, and as I say, and being research driven as well. I think it could, those kind of things are massive for changing how we deliver care.
Now, I always say this is the fastest hour in the week, and it has been, and my brain is buzzing from both of your presentations, because there's so much for us to think about. Now, those of you who are watching, you might want to play this again, because there's so much. I know Emily packed so much in, but also Susan did too. And there's so many things to think about and challenge ourselves as practitioners in what we're doing on a day-to-day basis, and maybe how we offer women choice about home birth, for example. And for those educators who are salivating at the thought of having a wonderful learning space like Emily's, and it's too much excitement, but you too could get that £1 million space. You need to contact Emily because she might have some very good tips for you. So I want to say a huge thank you to the audience who've been with us all the way through, and also to Susan and Emily, who've given us so much to think about. It's food for our brains. We're coming up in the next couple of weeks for food for our bodies, so we need some food for the brains to keep ourselves going. I want to say a huge thank you to both of you for making time to come and share your expertise and your passion, and that's come through so beautifully for both of you, so thank you so much. I also want to say thank you to Angelo, who's at the background making sure it's all being recorded for everybody, so you can replay it and you can share it with your colleagues and over a coffee break or a lunch break. Maybe you have a little bit more time. Now, resources are going to be available for those of you who want the podcast at 6 o'clock in the morning on Friday. It'll be available, and it'll be available next week through the newsletter. There'll be a link. Now, we're going to have a break now for the Christmas break until the 15th of January, and we've got lots and lots of delicious things for series 15. I can't believe I'm saying series 15. We're coming into our 5th year of this. We've got Anne Remmers and Laura Lewinson, who are going to talk about Black maternity matters, always an issue at the moment to really address that. We've got Enabling Quality and Safe Maternity Services in Northern Ireland with Professor Mary Renfrew. We've got Homelessness and Pregnancy with Sarah Cummings and Dr. Monica Lackenpaul, and Supporting Women with Disabilities through Pregnancy, Birth and Beyond. And that's just the first month. So you can imagine you're going to get lots of more food for thought for you. So I want to say, take care of yourselves, stay safe and well, look after yourselves and your families, and enjoy the festive period, whichever religion you hold, whichever. Just have a break, maybe eat a little bit too much, go to the carol services if that's what you'd like to do. Bit of rest and recreation, bit of chocolate, have some fun if you can. And I know that for the majority of midwives who are working so hard, that you sometimes can forget that. Also, I need to remind you, because this is on your resources, of the lovely Action for Happiness calendar, my very favourite calendar. There are little things on this. I haven't talked about this for a while, but the link is on your little resources, but it's full of little things that just little mindful things to think about. Today's was buy an extra item and donate it to the local food bank. And tomorrow, the 12th, be generous. And midwives, when I looked at this, I thought this is designed for midwives. Be generous, feed someone with food, love or kindness, or all three actually today. So that can be your tomorrow's little task. Thank you for being with us. Thank you again to Susan and Emily. We'll have them back again. We have to carry on with the debate. But in the meantime, take care. See you after Christmas in January.
Thank you. Bye-bye.
Thank you.
Thank you for joining us for the Maternity and Midwifery Hour. This podcast has been made possible by the team at Maternity and Midwifery Forum and our CPD partners, Matflix. You can sign up at matflix.co.uk.